Most cardiologists will agree that it is very difficult to make the diagnosis of constriction, probably because it has a very complex physiology. In any case, constriction is underdiagnosed. Still, with the help of echo and with the help of the tips that I will give you in this chapter, I believe we can make the diagnosis in most patients. We just have to be aware of the problem and know what to look for. Pericardial effusion occurs in approximately 9% of patients with pericardial effusion. But, as we already saw in previous chapters, it depends very much on which etiology of pericardial effusion you have. And not all patients will have a severe form of constriction, and some patients might only have a transient form. But if you do have pericardial constriction, prognosis is usually poor. But again, prognosis also depends on the etiology of constriction. It is much worse if you have radiation, opposed to an idiopathic form, or if it occurs after cardiac surgery. Constrictive pericarditis is the result of scarring and consequent loss of elasticity of the pericardial sac. It usually occurs as a result of chronic inflammation, and we often see calcifications of the pericardium, as you can see here in this image. However, we do not necessarily have to see calcifications. Sometimes the pericardium is only thickened, and this is difficult to detect not only with echocardiography but also with other imaging modalities. Importantly, it depends very much on how much and how severely the thickening and calcification of the pericardium is. Sometimes you might only have occult forms or only subacute forms of pericardial constriction. An important hallmark of the disease is the fact that patients have normal left ventricular function. The myocardium itself is not affected. It is important to know the hemodynamic sequels and the symptoms of constrictive pericarditis because they can often lead to the diagnosis. And the hemodynamic sequel is that of impaired filling, which causes venous distension, edema, hepatomegaly, and ascites. The history of the patient is also important. Usually they will have a history of pericarditis, especially bacterial or tuberculosis, or radiation, or they had cardiac surgery. Some patients have connective tissue disease, but still in some patients you will not find a reason why they have constrictive pericarditis at all. Constriction usually develops rather slowly, so you will have a latency sometimes of 5 to 10 years or even more. And again, some patients will only have transient forms of constriction. There have been attempts to classify pericardial constriction based on where the thickening and calcification of the pericardium is. However, in reality and with echocardiography, this is very difficult to do. Usually we're happy if we can just make the diagnosis. But for surgeons, this certainly is an important point because if they want to treat constriction, they have to know where the thickening and where the calcification is. But they do that usually based on inspection. But for us, it's important to know that constriction can involve both ventricles or only one ventricle. It can also involve the pericardium around the atria, and it can also lead to atrophy of the myocardium. Here's a beautiful CT image which shows you that the calcification is confined to the left ventricle, maybe a bit also towards the right ventricle here. But now let's turn to the physiology of constriction. Well, not surprisingly, if there is a shell around the heart, then we have problems to actually fill the heart. So the key feature here is we have impairment of biventricular filling. So as you can see, tamponade and constriction are very similar with respect to their physiology. But during tamponade, we have pandiastolic filling impairment, while during constriction, there is resistance-free early diastolic filling. Is it easy to make the differential diagnosis between tamponade and constriction? Well, in the most cases it actually is, but simply because we have pericardial effusion in the setting of tamponade while we don't in constriction. At least not always, because, as you will see later, there is also a disease entity called seroeffusive constriction. But let's come back to the way the ventricle fills during diastole in the setting of constriction. This is a pressure tracing of the left ventricle. And remember, During early diastole, we have unimpaired or free filling of the left ventricle. So we have rather rapid filling and rapid pressure rise in the left ventricle. Then, however, we have a resistance to filling caused by the tight pericardium, and we don't have any further pressure rise. We have pressure equilibration. In other words, we have a very typical shape of the diastolic curve of the left ventricle, and also of the right ventricle actually, which is called dip and plateau, or also the square root sign. This is a typical finding you will see in the setting of constriction. But to make the diagnosis with echo, there's another physiologic feature which is more important. A feature we already encountered in the setting of tamponade, and it is that of interventricular dependence. Let us review what happens. Remember, during inspiration we have more flow to the right ventricle simply because there is suction caused by negative intrathoracic pressure. Normally, the right ventricle can expand to all sides, and normally we have fairly high pressures in the left ventricle because we have no impairment to filling of the left ventricle via the pulmonary veins. In tamponade, we have augmentation of venous return to the right heart during inspiration. Now this mechanism is a bit different in the setting of constriction. In contrast to cardiac tamponade, the inelastic fibroelastic pericardial shell kind of isolates the heart from the lungs, and therefore the respiratory changes in the intrathoracic pressure are not fully transmitted to the cardiac chambers. But because during constriction there is also a significant reduction in the pulmonary venous pressure during inspiration, and therefore the left ventricle filling is also impaired, we do have a bit more flow into the right heart during inspiration. Another factor that plays a role is that we have an elevated intra-abdominal pressure which pushes the blood from the systemic venous return also into the heart. Also keep in mind that constriction is often not complete. So to some degree at least, the intrathoracic pressure is transmitted at least partially to the cardiac chambers. But whatever the mechanism is, the appearance looks very similar to what we have in tamponade. We have a shift of the interventricular septum, usually during inspiration, towards the left ventricle. This interventricular dependence can also be displayed with the help of catheter and with pressure tracings in the left and at the right ventricle simultaneously. What you see here is that we have a fairly high gradient of pressure between the left ventricle and the right ventricle, but as soon as inspiration happens, this pressure gradient drops. So to summarize the physiology, we have rapid early filling, augmented systemic venous return during inspiration, interventricular dependence, and eventually a drop in stroke volume and in cardiac output. I know the physiology of pericardial constriction is hard to swallow, but everybody has its problems with the physiology. But now let's turn to something which is easier. Let's see how this physiology translates to the echo and what typical echo signs we see. So what are the features in echocardiography? Pericardial calcification, rapid termination of diastole, and a septal bounce in early diastole, in particular during inspiration. Now, pericardial calcification is often very difficult to see. Why? Well, because calcification gives you artifacts and shadowing, so basically what you will usually note is that you can't image the heart at all or only poorly. So in many patients with constriction, you will have poor image quality. Take a look at this image of a patient who has pericardial constriction. Note how the ventricle fills. All of a sudden, we have an abrupt stop of outward motion of the myocardium. In addition, you can see that there is an abnormal motion of the interventricular septum. This is the septal bounce. Also take a look at the contour of the right ventricle here. You have the impression that there is an indentation here, as if a calcified clamp were sitting here which constricts the right ventricle. It's often quite difficult to really see the features of constriction such as the septal bounce. So here is another example. This patient also has constriction. Look at the motion of the interventricular septum. It bounces back and forth between the left ventricle and the right ventricle. To visualize the septal bounce, you can actually use any view where you can see the interventricular septum. You can even use M mode. And it is also helpful to use a respiratory curve where you can see that the septal bounce is augmented during inspiration. Here's such an example. We have a respiratory curve here, and if you note exactly at the moment of inspiration, we have an augmentation of the motion of the interventricular septum towards the left. As you will see later with echocardiography, we can also see other features of constriction. But personally, I believe that the septal bounce, if you have the experience to visualize it, is probably the most diagnostic finding. Here are some other things that you can see with 2D echo. We have hypermobile AV valves caused by rapid early filling. But you can also see pericardial adhesions. In the setting of constriction, we often have obliteration of the parietal and the visceral layer of the pericardium. And often the pericardium is still attached to the surrounding tissues. And therefore, it is sometimes possible, as you can see in this example, that adjacent tissue moves with the heart. Of course, this is not a diagnostic finding either, but it's part of the puzzle. Here's another example, a 4-chamber view where we are focusing on the right ventricle. This patient has a more seroeffusive type of pericardial constriction. There's probably a form of organized pericardial effusion here. But nevertheless, we see a motion of the pericardium and the adjacent tissue parallel to the motion of the right ventricle. This can also be demonstrated with the help of M-mode. Note how the pericardium and the adjacent tissue parallels the motion of the right ventricle. This usually does not happen to the same extent if we only have pericardial effusion without constriction. Now let's turn to systemic venous return and let's look at the inferior vena cava. In the setting of constriction, you will always have a dilated inferior vena cava and dilated hepatic veins. The assessment of hepatic venous flow is often very difficult and fairly complex, but basically it mirrors the hemodynamics that we talked about earlier. What we find is we find a predominant forward flow in early diastole. You can see this nicely in this image here. Most of the flow occurs during diastole and not during systole. In addition, we have augmentation of forward flow during inspiration. And finally, we also see an augmentation of expiratory flow reversal of the hepatic veins. There's one more sign that we have to discuss. Tissue Doppler. Tissue Doppler can help us to differentiate between restrictive cardiomyopathy and pericardial constriction. As you can see in this example, in the setting of constriction, we have a fairly high E' wave, which corresponds with a rigorous motion of the mitral valve annulus. This is not the case if we have restrictive cardiomyopathy. It is not easy to make the diagnosis of pericardial constriction. Often you will have ambiguous findings, and very frequently will you also need cath studies to document the hemodynamic changes associated with constriction. But if you put all the pieces together, especially also looking at the clinics of the patient, you can usually make the diagnosis. In conclusion, I would like to show you 2 cases. The first is that of fibrinous pericarditis. Here we have a pericardial effusion, we have no compression of the chambers, and we have no septal bounce. So this is not indicative of hemodynamic significant pericardial effusion or of constriction. The mitral inflow signal also shows only mild fluctuations with a mild decrease during inspiration. And in the M mode, we see no adherence of the pericardium or the surrounding structures to the myocardium. But because the patient has fibrinous pericarditis, we have to perform follow-up studies to see if he does develop constriction at a later time. And this here is a patient who is developing constriction after fibrinous pericarditis. Note that we have pericardial effusion with a lot of fibrous strands within the pericardium, and that we do have abnormal motion of the interventricular septum. There is a septal bounce. In addition, you can see that there are respiratory variations with a steep decrease in the velocity during inspiration, and we also have a fairly high E wave with pulse wave Doppler across the mitral valve. So this is an example of a patient who has pericardial effusion and constriction at the same time. This is what we call seroeffusive pericardial constriction. So keep in mind, there are several ways how pericardial disease can lead to inflow obstruction to the heart. We can have tamponade, then we have fluid accumulation in the pericardial sac. We can have a stiff pericardium, then we have pericardial constriction. Or we can have a combination of 2, effusive constriction. In conclusion, I want to again emphasize the importance of the typical clinical findings in patients with pericardial constriction, peripheral edema, and signs which are compatible with right heart failure. If you cannot find an explanation for these symptoms, you have to suspect pericardial constriction. And then you have to use all the tools which are available to you. Echo tools, but also MRI, CT, and up front also cath studies. And keep in mind, some patients might be volume depleted, especially if they receive diuretics. In these patients, the symptoms and typical findings might not be as prominent as in patients who have full-blown pericardial constriction.